Hi, my name is Dr. Joe Murray. I'm a gastroenterologist at the Mayo Clinic in Rochester, and I focus on celiac disease. Today I'd like to discuss a recent article published in the journal Clinical Gastroenterology and Hepatology by Park et al. From Palo Alto and Stanford Medical Center in California. This very interesting paper modeled two approaches to identifying patients with celiac disease and what that impact would have on bone health. We know that celiac disease can affect the development of normal healthy bones, and patients with celiac disease are very prone to conditions such as osteoporosis or another condition called osteomalacia. The second causes softening of the bones. These two conditions can lead to an increased risk of fractures, and it's now long been known that patients with celiac disease have an increased risk of fracture before diagnosis, and that risk may persist even after diagnosis, especially in people diagnosed as adults. This study examined two strategies. The first strategy is what I would be the best current practices, or selected screening testing in patients who have got symptoms or conditions that we know are associated with increased risk of celiac disease. The second strategy is universal screening strategy. That is testing everybody at 12 years of age for celiac disease. And those patients who have a positive blood test would then be subjected to an endoscopy and biopsy to confirm the diagnosis. So what this study by Park et al. Did was it compared these two strategies, and basically with the Markov modeling done, it maps out what the consequences of each screening strategy are for the patient's bone health, in particular the risks for vertebral and hip fractures. Now, why do they pick these particular fracture types? One, because they're a major cause of morbidity and possibly contributor to mortality in the population. And secondly, the typical measurement undertaken for bone density measures hip and spine. In this study, which looked at costs, so they were looking at the perspective essentially of an insurance provider, the costs of the strategy of universal screening at the age of 12 was considered inferior or more costly than the selected screening strategy. And so they suggested that based on their modeling, that the current practice, or current best practice, of selectively screening patients with suspicious symptoms or syndromes or other diseases is probably the most cost-effective at the current time. Now, what does this mean when we look at this type of modeling exercise? Well, it's taking the information that we have about diseases and their outcomes, and it puts them into a computer and allows the computer to help us model, in this case, the cost. Now, I think there are some important limitations to this. This is not a real patient study. This is not following 1,000 people and comparing them with one strategy or another. This is modeling it, and there are some assumptions. One is that the fracture risk is largely related to hip and vertebra, whereas several studies, observational studies, identify that many of the fractures that occur in celiac disease are related to the periphery. Now, these can be good in that they don't have the same long-term impact as hip or spine have, but also they can be very problematic. The second thing is that the screening paradigm is to undertake a single tissue transglutaminase IgA blood test, and if the test is positive, to go on to biopsy. And even though this test on its own in clinical medicine works very well, its accuracy is not sufficient. I believe, and research that we've undertaken and others have undertaken, it's not sufficient alone to subject somebody to an endoscopy. And that there are now strategies by, for example, doing sequential testing. For example, taking any positive tissue transglutaminase IgA result and doing an endomesial antibody test that this second test can really help select those patients who are most likely to have celiac disease. Perhaps even in some circumstances, by combining blood tests, it may be possible to reduce the need for doing intestinal biopsies in this setting. These types of nuanced approaches to diagnosis, especially in the general population, may substantially reduce the cost of universal screening. And really our goal is to identify all of the people who have celiac disease who need to be found, find them before they've had consequences. And many of those bone consequences, and once somebody is diagnosed at advanced age in life, they may already have missed much of their ability to regenerate or even to generate a normal bone density or bone health. So this publication, I believe, opens up a very important area of studying what it is we need to know about who and when and how to test for celiac disease, and is part of and will be part of an ongoing debate about how best to find this increasingly common disease. Thank you.